Hi, welcome. I am Julie Hirschberg, the owner of Reactive Therapy and Wellness here in the Los Angeles area. And joining you today, like I have been doing every week, although we've been off for a couple of weeks for the holidays, but just to share what we are doing, what we're learning. And a big piece of what we're learning and doing has to do with our fellowship program. So we run the only fellowship program at the moment for physical therapists to specialize in movement disorders. And very proud that we do that. And I learn a lot doing that. Part of that is we put together a series of courses over the year to train therapists in movement disorders. And that's why I'm coming to you today is to share what we've been learning, what we've been doing. We had our first mini course last night, and it was on differential diagnosis, advanced differential diagnosis for movement disorders for physical therapists and occupational therapists. So this is kind of the backbone of what we do as therapists, because in order to set up a really good plan for somebody, we need to know what is going on. And we don't always know. We might not have a clear picture of a diagnosis, or it might still be uncertain. And so our screening goes a long way. Now, I do have to say, disclaimer, we are not neurologists. We're not providing diagnoses. And I always recommend somebody see a movement disorder specialist to get a proper diagnosis. So this video is not a diagnosis video for people. So let me tell you a little bit about what we're going to talk about today. So, I want to share something that I've been so excited about. It's right here. This is our framework. We put it into a pocket guide. It's a framework for differential diagnosis in movement disorders for PTs and OTs. So, I'm going to talk through that framework and how we put it into the pocket guide. I'm going to share a few of the nuggets from our course last night about tremor, some great articles that I read and we shared. And then the next step with this information is connecting with a movement disorder specialist, whether that's the person that referred them or not, but having that conversation and discussing findings. So those three things, a lot for one little Friday afternoon. So let's dive into this framework first. So I put together this framework and this pocket guide so that you could have everything in one place, really easy to find. And basically, what I did is took a lot of my work in differential diagnosis, the stuff that I teach at USC, and I applied it, as well as some literature, applied it to a framework that a PT or OT could easily use. It goes step by step. So we go, are they moving differently than expected? What is the category of movement? Is it hypo or hyperkinetic? Does it have a functional component? So we spent a lot of time on this last night. And then what is the etiology? What's the underlying cause? Is it hereditary? Is it sporadic? Is it a neurologic disease, or is it combined? And we spent a lot of time in our course last night going through that first question is, are they moving typical? This question comes up a lot in the world of movement disorders, specifically Parkinson's, because we may see somebody that was referred to us with Parkinson's and we go, that seems a little unusual. And so the first part of this framework is to then ask that question, is it typical? And in Parkinson's, there's a few signs that are very atypical, like it's not responding to medication, like it's got a symmetrical onset. The person's falling backwards very frequently. These are some of the signs that there might be a Parkinsonism versus Parkinson's. So in this pocket guide, by the way, I'll put a link so you can download it. We actually have a table of the common Parkinson's Parkinsonisms and how to differentiate them from Parkinson's disease. So MSA, CBD, PSP, a lot of letters there, but all different types of the Parkinsonism. So that's step one. Step two in the framework then is if there's abnormal movement, is to help us characterize it as hypokinetic or hyperkinetic. Hypokinetic meaning less movement, hyperkinetic meaning too much movement. And then in the hyperkinetic, to go into jerky movements or non jerky. You've heard me talk about some of this before. Question three is, does the movement have a functional component? This becomes very important for us as therapists because that functional connectivity problem, for one, that's something that we can very specifically intervene and improve. And it often overlays another neurologic disorder. So we need to tease those out. So with movement disorders, for tremor, for myoclonus, for the chorea, if any of those are functional, we would look for these things. Is it variable, distractible? Is the tremor entrainable? Is there a positive Hoover sign? Did it have a sudden onset out of nowhere versus some of that like slowly progressive and other movement disorders? So that is question three. Question one, are they moving differently than expected, or is it typical? Question two, if there's an abnormal movement, how do we categorize it? Hypokinetic, hyperkinetic. If it's hyper, is it jerky or non-jerky? Does the movement have a functional component, variable, suppressible, distractible, all those characteristics? And then we need to unlock and uncover the etiology. This is where we're working very closely with a neurologist who's doing maybe genetic tests, doing imaging, all of those things to rule in and rule out other neurologic disorders. So that's the framework that helps us with differential. In the pocket guide, I have that step by step, and then we've got these great tables to go through the hyperkinetic disorders. So we go through the non-jerky, so dystonia and tremor, and we go through the jerky. We talk about, we've got these lovely little tables. So myoclonus, chorea, tics as well. So you can easily sort through it as a therapist. So again, I'll put a link in here, great resource for the therapist looking to improve their differential diagnosis skills in movement disorders. So that's our framework. That's the first thing that we talked about in our course last night. And then we went into a lot of practice, a ton of video looking at different cases and trying to determine if something is a what kind of tremor it is. So for example, we talked through essential tremor, Parkinsonian tremor, cerebellar tremor, which isn't actually a true tremor, it's dysmetria. But one of the nuggets that I really wanted to share was a really lovely article. I will put the link in the comments here. Oh, and I see a great comment to where to find the pocket guide. I'll throw that link in there right now because you can just download it. You'll get it in your email right here. So that's a link to the pocket guide. I will also put a link in for this really great article. I loved this article. So at the beginning of 2020, the Neuropsychiatry Journal had a full issue on functional disorders. And I'm putting a link here in the comments to this article. And I downloaded the whole issue, by the way. It's free, full text online, so I put that in there for you. But they had an article looking at functional disorders in Parkinson's and finding that functional symptoms, functional motor symptoms, can be very common. And also that a subset of functional movement disorders are actually functional Parkinsonism. And in the supplement of this article, they had a really lovely table. And I put this table into our course last night, but comparing some of the symptoms of Parkinson's versus functional Parkinsonism. So in Parkinson's, we see a very typical rest tremor. It often involves the fingers. It's very slow, maybe 4 to 6 hertz. You can sometimes have different frequencies in different parts of the body, and it often increases under stress or like mental calculation, dual task. Um, and is, it's not transmitted to other parts of the body if you hold the hand down. So those are some features of a Parkinsonian tremor. And I just want to contrast that. We talked about this last night in our course to what if somebody had a functional Parkinsonism? So in that case with the tremor, it's during rest, it's during posture, it's during action, and it's often not including the fingers. The frequency is variable, so it's not always at that, 4 to 6 hertz. It's an entrainable tremor, meaning it can train to another frequency. It often has the same frequency in different parts of the body. It decreases with distraction. And when holding the limb down, it may actually translate to other parts of the body. So if that is the type of tremor that somebody is seeing in a functional in Parkinson's, that may indicate more of a functional Parkinsonism, meaning a connectivity issue. What is so interesting, and the authors state this in the article as well, is that this is really a clear sign that movement disorders like Parkinson's and functional movement disorders likely have some common connectivity problems. So basal ganglia involved, cerebellum involved, that circuitry is likely has a common factor. So profound, I think, that still has me thinking, like, what does this mean? But for us as therapists to tease these out, we know that very specific interventions work very well for functional connectivity disorders. And so we might be able to help somebody very specifically if we're seeing those signs and symptoms. Okay, so that was one little piece from our course last night I wanted to share with you. So I shared the framework. We shared a little bit of what we learned about tremor. And then lastly, and somebody in the course asked this last night too, is how to connect to somebody, a movement disorder specialist, to help navigate these diagnoses. And you've heard me say this many times. I think a movement disorder specialist is so important to distinguish these different movement disorders. So distinguishing between the different types of myoclonus, different types of tremor, different causes of dystonia. To have a movement disorder specialist who can do that. And then we as therapists can connect to and discuss. So something that I really recommend is getting out there with the movement disorder specialist. So that's really how I started and got going at Re+active, was to connect to colleagues who had a very similar interest of mine, neurologists, movement disorder specialists, who were interested in therapy, in curious questions about movement disorders. So some of them I had known through my residency training, but also just connecting with others who had a similar interest. So that might be through doing a continuing education course in movement disorders and meeting other people through teaching a lot about this. I also really loved going to appointments with my patients as much as I could. We can't do that all of the time, but as much as I could, that was a really good way to connect and chat with a movement disorder specialist and learn so much. I learned so much by being within an evaluation or treatment session with somebody. So those are some of the ways that I've really connected with specialists and stay connected. Just last night, we had a phone call with the group that we work with at UCLA from their movement disorders clinic. And we brought up this article that I just shared with you. And we got to discuss, our cases and what this means and what do we think about this. And so that ongoing discussion is really important. We do that once a month with our colleagues at UCLA. It's part of our fellowship program. So that's another really great way to stay connected, is to have ongoing training and learning in movement disorders. That's how we're doing it. I will also put a plug in. One of my favorite neurologists to work with, movement disorder specialist, is Alan Wu. He was at UCLA. He is now at Northwestern, and literally he emailed me this week that he's building up his clinic and he's taking patients, and he can see patients from all over the US via telemedicine, and he is phenomenal when it comes to movement disorders. So, if you are looking for somebody and you're looking to connect with a really great physician, Alan Wu, I'll put his name in here, Alan Wu, Northwestern, movement disorders, and highly, highly recommend him if you are looking for a referral for a patient, if you are somebody looking to work with a really great specialist, um, and maybe get another opinion, he would be a great resource for you. So there you have it. I got to bring to you some of the great things, the fun that we had last night, really diving into this framework. So I put the link in here so you can download this for yourself. I've definitely already been using it, and it's something that we're using at Re+active within our fellowship a lot. So download the framework. We talked about tremor, Parkinsonian tremor, functional Parkinsonism. I put the link to the article in there as well. And then we talked about connecting to a movement disorder specialist to be able to discuss your findings from differential diagnosis. So thanks so much for joining me today for this dive into movement disorders. I'll be back next week as well, and I hope you have a lovely weekend.